Welcome everyone to the Canadian Nurses Association's webinar series, Progress and Practice. This webinar is entitled A New Application Kit for the Canada Pension Plan Disability Benefits. This session is being recorded for nurses who are unable to participate today. My name is Josette Rousset. I'm a program lead in nursing practice and policy at the Canadian Nurses Association, and I will be hosting the webinar today. At the end of the presentation, there will be a question and answer period, and we will address as many questions as we can. Now I'd like to tell you a little bit about our presenter, Jane Graham. Formerly a registered dietitian working in a hospital setting, Jane holds a master's degrees in health administration from the University of Ottawa. A veteran of the CPP Disability Program with 20 years experience, she currently leads the medical policy team within the medical expertise division. Jane was instrumental in the development of the new CPP Disability Application Kit, drawing from evidence-based research into the functional assessment of work disability. Over to you, Jane.
Thank you, Josette. So first of all, thank you to CNA for inviting us here today to speak to you about the new application kit. The kit just launched on August 27th, so it's very, very new, and as with all launches, there's always going to be a few little growing pains, which we fully anticipate, but we're hoping that in speaking with you today and addressing any of your questions that we can minimize those growing pains. All right, so I'll start just by giving you a little bit of an overview of the presentation. I hope everybody can hear me well. If not, maybe you can just signal in the chat that you're having trouble. I have a fairly soft voice, so I have to make an effort to project. All right, so the purpose of today's presentation is to do a walkthrough of the new application kit and to outline the new structure and format of the forms. I will be spending the bulk of the presentation discussing the medical report because that's the form that you will be completing as nurse practitioners. But I will also touch briefly on the client questionnaire because I want you to understand the broader context. In other words, what information will we receive from your patient or the applicant, and then how that will be compared and corroborated with the information that you provide us. And as we do this walkthrough, I'm hoping to give you some, very practical strategies and tips for completing the forms in a manner that will ensure a fair and timely eligibility decision for your patient. All right, so before we get into the actual forms themselves, I thought maybe we would start out just with a little bit of background information about why we embarked down this road in the first place. So as noted in this slide, in response to various drivers, including the Auditor General's report of 2015, which frankly levied some fairly harsh criticisms against the program and against the application process itself, extensive work began within the department to simplify and streamline the application process. So this involved, a head-to-toe review of the current process, and which included the forms, the guides, the procedures, everything. And as part of this scoping exercise, we also held consultations with a number of different groups, including clients, in other words, people that had previously been through the application process using the old set of forms, as well as representatives or advocates who support these individuals in the application process. We also talked to a number of key health stakeholders, so that would include, of course, yourselves, Canadian Nurses Association. We also talked to the Canadian Medical Association and the College of Family Physicians. And of course, we also talked to employees of the program themselves because as individuals who are moving this paper around and processing these applications, they also were aware of some problems that needed to be addressed. So flipping to the next slide. So these assessments and consultations resulted in some very useful feedback. And essentially what the feedback told us, and we already kind of knew this, but it really reinforced what we already knew, was that the process itself is highly complex. And many clients and advocates felt that there was inadequate information on the eligibility criteria for the program, which of course refers to the definitions for severe and prolonged, which by the way are outlined in the new forms, and I'll draw your attention to that as we move through. Employees of the program also found that the process complexities contributed to skipped or overlooked questions. So the questions were simply left blank because people didn't know how to answer them. And also poor quality responses and just general delays in submitting supporting medical documentation that was leading to extended processing times and delays in payment delivery. So the overall kind of common voice that we heard was that there was an expectation that we really, really needed to simplify the overall process and also just to increase awareness of the program itself, because many people who fall ill are not immediately made aware of the program. And so as time moves on, they run out of contributions, earnings and contributions to qualify for the program, which means that we then have to look at them as a late applicant, which becomes much more complicated because we have to go and get historical medical information. So ideally, we want people to apply as soon as possible because it makes the adjudication easier. So flipping to the next slide. So again, as part of the scoping exercise for this project, we identified some guiding principles. These were sort of, overarching statements of a vision that we had for the new kit. So from the outset, we said, okay, we're only going to collect information that is essential to assessing eligibility and entitlement. So we're not going to ask any kinds of questions that aren't actually going to be used in the application process. We're going to eliminate questions where the information is already available. So as an example, in the old form, we used to ask them to identify their sex or their gender, male or female. And we don't ask that anymore because through the social insurance registry, as soon as they give us their social insurance number, we automatically know their sex at birth. Now, granted, their gender may have changed over the life course, but the sex is as it was recorded on the social insurance registry. We also made a real effort to use plain language and plain language terms. So we put the new kit through a professional plain language editor to ensure that our literacy level was at or below grade 8. We also made an effort to amalgamate several of the forms. So I don't know, for those of you who may have been filling out the forms previously as part of a multidisciplinary clinic, we used to have 8 forms in total. So a number of these forms were filled out by the client and a number by the healthcare provider. But anyway, it became sort of this nightmare to try and have to download all these forms from the internet and keep everything straight. So we've got rid of these 8 forms and we've condensed everything down into 2 forms to make it a lot easier for both the client and for the healthcare provider. And we've also embedded some, we call them behavioral insights. So this is in marketing languages, nudging. So in certain sections, we've added some little prompts or some little instructions where we're looking for the applicant or the healthcare provider to provide us with very specific information. So we've embedded those tips within the form to facilitate the navigation of the forms. Okay, so what does this all mean for healthcare professionals? Well, first and foremost, nurse practitioners may now certify regular medical reports as well as the terminal illness medical attestation. So those are 2 separate forms, and I'll speak to both of them in detail as we move through the presentation. I just want to underscore again that the eligibility criteria for the program remain unchanged, so we're still operating under the same legislation of severe and prolonged. However, the medical report has been refocused to capture more detailed information on the functional impacts of impairments. This is a big, big change for us. And this will be coupled or mirrored with the patient's self-report to provide a valuable cross-reference to the medical evidence that is provided by yourselves. Another big change is that we have introduced a clearer definition for terminal illness. In the past, we've always had sort of a fast queue or an expedited processing queue for terminal cases, but we didn't have a formal definition. And what we were finding was that terminal is subject to interpretation. So depending on, which doctor we were referring to or which patient, they were interpreting terminal in different ways. So we've now got a formal definition, which basically says that the individual is expected to pass within a 6-month time frame. And obviously, if the client ends up passing in 8 months, it doesn't, they're not going to be penalized from the point of view of the benefit. It's just that what we're trying to do here is to really use our resources efficiently so that the people that are truly dying or imminently dying are put in the really fast queue, and that if they have a grave condition, which I'll talk about in a few minutes, if it's grave, if it's serious, but they're not dying immediately, they don't need to be in that very, very fast queue. And with terminal, we have 2 points of access. So we have a dedicated terminal form. And for those applicants that perhaps are unaware of the dedicated form and end up using the regular form, there's also kind of an off-ramp built into that form so that the healthcare provider doesn't have to fill out the entire form. And I'll flag that for you when we're walking through the forms. All right, so flipping slides. So we're now going to take a deep dive into the regular application kit. So there's 2 forms. It includes the client application and the medical report. And I believe Leah sent you copies of these forms before today's webinar, and I'm hoping you've had a chance to maybe print them and maybe just give them a cursory look. But if not, don't worry, we have some screenshots. They're not super legible, but anyway, I'll try and guide you to the corresponding page that's in the actual report. Okay, so the next slide just gives us kind of a high-level bird's eye view of what has changed. So again, I just want to reiterate, the legislative framework for the program has not changed. It's still severe and prolonged, and the definitions for severe and prolonged are provided within the form. So if you have the forms in front of you, on the client questionnaire, the definition is listed on the front page. And for the medical report, the definition of severe and prolonged is listed on page 3. There were some questions sent to us before today's session, and someone was asking about the definitions, and that's why I'm flagging it for you. And the person that was submitting the question referred to a serious medical condition. The term serious is actually not part of our legislation. The term that we use is severe, so it's severe and prolonged. And severe refers to whether or not the individual has a disability that stops them from doing any type of substantially gainful work. And prolonged means that the disability is long-term and of indefinite duration or is likely to result in death. So really the definition of our program is rooted in employability. The mere fact that someone has a diagnosis and that it's serious doesn't ensure eligibility for the program. It has to, the condition has to be long-lasting, and it has to interfere with their ability to find, seek, and maintain employment. So the legislative framework has not changed. However, the conceptual framework has. So previously, we didn't really have, outside of the legislation, we didn't really have a conceptual framework to guide the structure and the flow of the form, whereas now we've applied the International Classification of Functioning Disability and Health, or the ICF, which again I'll talk about in a little bit more detail. The structure of the form, as I mentioned earlier, has been condensed or consolidated from 8 standalone forms down to 2 forms, including the client application and the medical report. The format of the forms now features more guided questions with very specific prompts, whereas previously the questions were more open-ended, and so both the client and the healthcare provider were having to provide these lengthy narrative responses, which were very time-consuming. In terms of, again, the focus of the forms, we're really trying to adopt more of a comprehensive focus, meaning we're looking at physical, cognitive, and emotional limitations. The old forms tended to focus more on physical. So, and again, that makes sense because this program started up in the 1960s when we largely had a manufacturing-based economy, and the physical element of function was really paramount to getting and keeping a job, whereas now we've moved more into a knowledge-based economy, and having a good, cognitive and emotional function is key to employability. So we're really trying to probe those elements in more detail today. And as I mentioned earlier, we have various off-ramps embedded within the forms to allow healthcare providers to essentially skip questions and provide an abbreviated set of evidence for the adjudication of terminal and grave conditions. All right, so moving to the next slide, I'm just going to touch very briefly on what we mean by functional assessment. So historically, most of the disability programs in the Western sphere, so I'm referring to our program, of course, and the American counterpart, which is the Social Security Administration Disability Insurance Program. These programs have tended to focus mainly on assessing physical and mental impairments. And again, this dates back from an earlier time in the 1960s, and that's how we kind of thought about disability. But over time, research has shown that diagnosis and impairment alone are frequently poor predictors of work disability. So you can have a very, very serious medical condition and still be perfectly employable. Or the reverse is true. You may have a condition that maybe by normal standards wouldn't be considered as serious, but because of how you as an individual respond to your pain or your fatigue or maybe your emotional coping style or your resilience does not allow you to withstand the demands, you're unable to work. So we really look at functional assessment on an individual basis within the context of the medical information. So thinking beyond just diagnosis and impairment, we're now trying to look towards conceptual frameworks such as the ICF, which depict disability really as the gap between the individual's functional capabilities, in other words, what can they do, versus what are the demands imposed by their environment, including a work setting. So I'm assuming that most of you are at least somewhat familiar with the ICF, but perhaps for those of you that haven't touched on it in your training, we just have one very quick slide that speaks to the ICF, and essentially it is the preeminent conceptual framework for describing and organizing information on functioning and disability using a standard language and standard measurement approach. And it was developed by the World Health Organization, and it is the sister classification to the ICD. So the ICD is used to label the diagnosis or the impairment, and the ICF in turn codes for the functional limitations. It's used globally in research, surveillance, reporting, and clinical assessments. So we've applied this lens to the forms to allow for a more holistic assessment of disability. Flipping to the next slide, this is just a very high-level overview of the ICF structure, and this is outlined in their data dictionary. So I won't delve too deeply here, but I just kind of want to situate this discussion for you so that you understand what areas we're really probing. So the ICF has 16 chapters devoted to body function and body structure. So this is really the body as the machine. And these descriptors give rise to traditional clinical assessments. So examples would be cardiopulmonary function, kidney function, lumbar spine function. So this is function in terms of the body structure. So I often, when I'm talking to non-medical people, I'll say to them, this is kind of like when your car is giving you some grief and you go to your mechanic and they lift up the hood and they look inside and they say, oh, you've got problems with your valves and pistons. So it's looking at the car or the body as a machine. And this is really describing the impairment. And this has been the historical focus of our forms. We're not erasing this type of assessment. This is still important. But now what we want to do is we want to marry that with a more holistic approach, which is looking at the whole person functioning from the point of view of activities and participation. So the activities and participation, these 9 chapters that you see here, we've embedded questions within the forms that touch on these. So flipping to the next slide. The next 2 slides just really are kind of highlighting, again, the difference between what we mean by impairment versus function. So impairment, again, is a problem in body function or structure. It's measured via tests, and it can also be observed via symptoms. So an impairment really describes how the patient feels, okay? Whereas the function is more what can they do, feeling versus doing. So function in this context is the execution of tasks and activities in life situations. So we realize that without putting the applicant through psychometric testing, you may not be able to provide a lot of detail on the function side, but to the extent that through your interactions with your patients, to the extent that you can comment on observed phenomena, or if there are tests that they have been for psychovocational testing or other type form, you know, neurocognitive testing. If there are those kinds of tests available, we would love to have them. If not, you as the practitioner can comment on what you've observed in your daily or in your interactions with the patient. So just flipping to the next slide, these are just again some examples. So the patient will present to their nurse practitioner saying, you know, describing feelings of being sad or anxious or irritable. That's how they feel, but what we want to know is how is that impacting them in terms of life situations, tasks, and activities. So flipping to the next slide. So here we're just showing you how we have structured the new client questionnaire and medical report. So essentially what we did was we collapsed 6 of the 9 work-related ICF activity and participation domains into 4 broad groupings: physical activities, behaviors and emotional abilities, communication and thinking abilities, and other daily abilities. And we've reflected these groupings within both the client application and the medical report. And again, the idea is that these are 2 sides of the same coin. So we'll get the client's perspective, and then we'll get the healthcare provider's perspective and marry them up to see what the overall profile looks like. And of course, in asking questions in these domains, we juxtapose this against the core demands of work, because regardless of what job a person occupies, there are certain common demands across all spheres of employment. So just flipping to the next slide, this is referring mainly to the client questionnaire. So in the client questionnaire itself, we've set up a grid of self-assessed questions describing functioning that have been adapted from existing existing psychometric instruments. So in other words, we didn't make up these questions. We looked to see what other instruments were out there that we could use for inspiration. And these questions that we're asking of the client, just to be clear, they will not generate a quantitative score. This is really a qualitative assessment. So we're looking for a subjective input into understanding the client's functional profile. So again, we're not scoring this, it's qualitative only. And the client's responses in turn will be reviewed within the context of the medical report to look for synergy in the information provided. So the next few screenshots are taken from the client questionnaire. So if you have the client questionnaire in front of you, you would be looking at page 7 of the client questionnaire. So this first grouping of questions refers to physical abilities. So again, as the healthcare provider, you probably will not see the client's responses. They will fill this out on their own. But we just wanted to give you a bit of an idea of what types of questions we're asking the client, so that you can sort of write to those, I guess, in your medical report to corroborate some of the information that's provided to us. So as you can see, there's a meta question at the beginning where the client can opt out of this section if it's not relevant. So if they have, let's say, a mental disorder and their physical functioning is just fine, the client can indicate that they do not have any problems with physical functions and they're going to skip this question. But if they have any physical impacts, we do want them to answer all of the questions. And we use an ordinal scale, which reflects their ability level on most days from excellent to poor. And again, these questions will not be scored. It's really just to get some subjective or qualitative information from the client. And then In this same section, we have a narrative box where the client can add some additional narrative details. So if they wanted to nuance their response, for example, to talk about the progression of their, their functional limitations, or, good days and bad days, as we often hear about. Some days they feel better, some days they feel worse. They may want to nuance their response. So this is where they would share this information. So mobility is the first set of questions. Then we move on to behaviors and emotional abilities. And again, this would be highly relevant to someone with a mental disorder, but it might also be highly relevant for somebody with a chronic pain condition where the pain is interfering with their sleep, and as their sleep function deteriorates, their behavioral and emotional function deteriorates alongside. So one of the tenets of the ICF is that it's ideologically neutral. So responses are not inferred on the basis of diagnosis alone. In theory, any diagnosis could result in responses in any of these categories. So the next slide is communication and thinking abilities. So again, the mind-body connection, a person may have a physical condition, but as a result of pain and fatigue, they may start to see some, or medication side effects, they may see some deficits in their thought processes, thinking and communication abilities. So we want them to fill out some questions here. And then the last slide is other daily abilities. So these are really the activities of daily living and the IADLs, the instrumental activities of daily living. So these are kind of cross-cutting. So there's both a physical and a cognitive element, and these are, whether you're working or not, these are things that most people have to do in their daily life. And if things are starting to go off the rails in terms of their ability to manage their personal care or their household, their finances, etc., that's probably a pretty good indication of their ability to work. All right, so again, as the healthcare provider, you're probably not going to see the client's responses because the client will mail in their questionnaire on their own. But you never know, the client may want to sit with you as the healthcare provider and ask for your assistance in filling this out. It'll probably be a case-by-case situation, but we wanted you just to be aware of what is being asked of the client. So now we're going to move on and spend more time talking about the medical report. And again, I'm assuming that most of you have the report in front of you. So the first two sections of the medical report, so pages 1 and 2, are actually filled out by the client, so you don't have to do anything there. So that just involves tombstone information and the consent to share information with Service Canada. Your obligations as nurse practitioners start in sections 3. So in section 3, we start out by just asking you some basic information about the duration of your relationship with the patient. So we basically kind of just want to know how well you know this patient. We know that with doctor shortages and nurse practitioner shortages that some clients don't have a primary care provider, and they're going to outpatient clinics and seeing healthcare providers that they've never seen before. So that would be something that we would need to know in the assessment process. It also helps us to ensure that we have a complete medical history. So again, I referred to late applicants. So these are individuals that who last met the contributory requirements in the past. And so in some instances, we have to go back in time to get historical medical information to make sure that the individual had a medical condition at the time when they last met the contributory requirements. So again, if they last met the contributory requirements 5 years ago, but you've only known them 2 years, then we would likely have to go and find another healthcare provider that knew them at that time, unless you had those historical records transferred from the previous provider. In section 4, so this is the expedited processing off-ramp that I referred to earlier. So our preference is that for terminal clients that they use the abbreviated condensed terminal illness application. We are aware, however, that sometimes applicants were not made aware of their terminal diagnosis. Maybe that conversation hasn't happened yet. between the healthcare provider and the client, or maybe the client's in denial. There's a whole range of scenarios. So in the event that a terminal client applies using the regular form, this is the off-ramp that you are provided with to indicate that the case is terminal, and this will actually allow you to skip over section 5 of the form. So this was a very big objective of ours going in, was we really wanted to reduce the reporting burden for healthcare providers. So you'll note that there are 2 questions embedded here. The first one is around terminal. And as I mentioned earlier, we have now established a more concrete definition for terminal. So terminal is defined as a disease state that cannot be cured or adequately treated and is reasonably expected to result in death within 6 months. Now, we realize you don't have a crystal ball. And if you're not sure if it's 6 months or 8 months, you can err on the side of the client and put 6 months. But if realistically the person is not going to die for another 2 or 3 years, we don't want you using this indicator, because this person doesn't need to have their application processed within 5 days. They can go through the grave stream or through the regular stream, because death isn't imminent. So the first question is around terminal. The second question is around grave. So for the purposes of CPP, a grave condition is defined as a condition that is included in the list of 32 severe and rapidly progressive medical conditions in Annex A. So if you flip to Annex A, and that's on the next slide, you'll see the list of conditions. So essentially, these are conditions with marked and severe functional limitations that have a high probability of meeting the CPP disability eligibility criteria. So it's not a guaranteed grant, but based on our historical administrative data, there's a very high probability, sort of 80% or higher, that these individuals will be granted the benefit. And so again, for this reason, we want to put them in the fast queue. So the fast queue for terminal is 5 days, and the fast queue for grave is 30 days. Yeah, so I'll probably get more questions from the audience on this when we get into the Q&A sections, but for now, I'll leave it there. So then, so we're going to move forward now into section 5. So this is really the meat of the medical report. So this is where we're looking for detailed information about the diagnosis, the associated impairments and associated functional limitations, and any treatment plan that's in place. So I'm just going to flag this because we were starting to see a few medical reports coming in, and some of them are not being filled in correctly. So I'm just going to flag this for you now. What we're looking for you to do is to use 1 page per medical condition. So you'll note that in the form, there are actually 3 pages in section 5. So if the person has 3 medical conditions, you would use 1 page per medical condition. If they have more medical conditions, you can always, photocopy or add an extra page. But for most people, 3 would be, sort of the upper limit. And we're looking for you to list these medical conditions in order of greatest functional impact. So if a person has degenerative disc disease and they also have clinical depression, and in your professional opinion, you think that the clinical depression is really what's driving the individual's inability to work, then you would list the clinical depression as the primary condition and the DDD as the second condition. So on this form, or on this page, you're going to list the name of the medical condition, the corresponding ICD-9 code. I've been made aware that some organizations or some practices are using ICD-10 now. It's sort of hit and miss. We're in that transition phase. Our preference is for you to use ICD-9, but if you're already using ICD-10 and it's too much work to translate it or to map it back to ICD-9, don't worry about it. We have mapping tables where we can do that. And we're looking also for the date of symptom onset. Okay, so this is when the patient first started reporting symptoms related to this medical condition. And this date is important to us because it may be used to set the person's payment date. So perhaps they apply in December, but the symptoms were first noted in your clinical records 6 months earlier. So we might set the payment date 6 months earlier as an example. So based on that medical condition, we want you to identify the relevant impairment. So this is from a body function or structure perspective, the historical perspective that we've always asked about. And in addition, we want you to provide any functional limitations. Now, again, you're probably not doing a lot of psychometric testing within your practice, but to the extent that you can comment on any observations that you've made in terms of the individual's functioning, or if there have been any tests done in terms of neurocognitive functioning, etc., you can include those with your submissions. So on this slide, you'll note that we've provided 2 examples. So we've got an incomplete form on the right and a complete form on the left. So obviously there's a lot more detail on the completed form. In the incomplete form, they listed the impairment as diffuse pain. Well, that's not very helpful. So we're looking for more information around sort of what the source of the pain might be, the severity, the frequency, just more detail around the nature of the pain. And in the functional limitations section, the healthcare provider wrote unable to do most activities. Well, again, we're looking for a little more detail than that. And again, you're not going to be able to comment at the same level of detail as the applicant because you don't live with the applicant, you're not in their body, you're not living their life. But to the extent that you can comment, if this person has been into your office, weekly for the last month, or monthly for the last year, and there's kind of a reoccurring theme that's emerging in those conversations around their ability to cope and withstand life's pressures, you can add that in the functional limitations section. We're then looking for some information on the prognosis, the expected duration, less than a year, more than a year, and the frequency. Do you see this as being a continuous situation or more of a recurrent episodic situation? We're then asking for information on medications and treatments. Now, you may have noticed that we also ask for this information in the client questionnaire. And while that may sound repetitive, we've done it deliberately because we recognize that many clients or many applicants see many doctors, and the healthcare provider filling out this form may not be fully aware of all of the medications that this individual is taking. So again, we're just looking for means to corroborate information. All right, so on the next slide, we provide another example of a well-completed form and a not so well-completed form. So on the incomplete form, you'll note that under functional limitations, they wrote cannot work. We're very interested in hearing your opinions about the individual's ability to work or not work, but you're actually going to save that opinion for section 6. In section 5, what we're looking for are tangible examples of why you think they can't work. So ultimately, the determination of can work or cannot work rests with Service Canada, but you need to justify why you think they can't work in this section. So continuing to the next slide, we're in section 6. So here's where we're talking about the patient's employment situation. So this is where you have the opportunity to comment on your perception of your patient's employability. So the first question is, did you recommend to your patient that they stop working? Yes, no, or not discussed. And if yes, when? Again, this date may be very important to us in terms of setting the date of onset for payment. And if the individual has a terminal medical condition, you can skip over the rest of the questions, but if they don't have a terminal medical condition, then you would continue responding. Question 2, from a strictly medical standpoint, do you expect your patient to return to any type of work in the future? Yes, no, unknown. It's fine to tick unknown. We don't, if you don't have a firm opinion on this, that's fine, but if you do have a firm opinion, we'd like to hear it. And if you do think that there's a glimmer of hope that they may go back to work, just some of the details around that, when and what type of work. And then finally in section 7, this is just kind of an open-ended question. Just a placeholder for where you can add any additional information that you think is relevant. So if you're kind of on the fence about the prognosis, the prognosis is guarded, you're just not really sure, here's where you can put in some details about why you're on the fence. If there's any planned investigations or consultations which may shed some light on the prognosis moving forward, this is where you can add those details. So just basically anything that you think is relevant to helping us establish whether or not the person is severe and prolonged. And then next slide, sections 8 and 9, this is where you will indicate any supporting documents. So longitudinal clinical notes, which give us that historical perspective, can be very, very valuable, especially for chronic pain cases and mental disorders, because as we all know, there is no empirical test to measure pain. Yes, you can do an X-ray or an MRI that may show some abnormalities, but the level of pain that people experience often does not correlate well with those objective findings. So being able to see your longitudinal clinical notes showing that the person has been complaining of pain for the last 2.5 years, for example, would be valuable to us because it helps to demonstrate the trajectory of the condition and the trajectory and progression, essentially. Any specialist reports, any hospital discharge reports, anything that you have on file that you think would be useful to corroborate the information provided by the applicant. And then in section 9, it's just the declaration. So you're just basically signing off, stating that the information that you've provided is complete and accurate, and indicating your area of practice. And yeah, so that's it for the medical report. So okay, it's now 20 to 1, so I'm going to go through the terminal illness application fairly quickly because I want to make sure we have time for Q's and A's afterwards. So the terminal illness application, again, is to be used in select cases where the prognosis is really not good and you're expecting your patient to probably die within the next 6 months, plus or minus. We have 2 means of identifying these cases. The first is the dedicated condensed terminal illness application, which we'll be discussing in a moment. And if for whatever reason that form is not used, we can use section 4 of the main medical report as an off-ramp so that you can bypass section 5 and large chunks of that form. The functional impacts that we spoke about earlier really don't apply in this context because obviously if somebody is dying within 6 months, we already know their functional status. So there's no need to ask them questions that really aren't relevant. And the attestation that we're asking of the medical provider, we're not asking for any supporting documentation. We're taking that attestation at face value. So basically you're attesting that the individual will die within 6 months, and we are taking that at face value unless there are any exceptional circumstances. So for example, if we find that the client is still working at the date of application, we might have to probe a little bit further, but generally the evidentiary requirements for terminal are significantly less because we're taking the attestation at face value. So turning to the next slide, we have a screenshot of the terminal illness application. So in section 3, this is really the meat of the attestation. So we're basically asking you 3 very simple questions. When did you first start treating the patient? Did you recommend that they stop working? If so, when? Again, that date may be helpful in setting the payment date. And when you last examined the patient. And then the diagnosis, the ICD code, and the date of symptom onset. And then the attestation is just confirmation that this is accurate information in relation to this particular application. Now, you'll notice at the bottom of the page, there's a box, and I'll just speak to this very briefly. So it says, if the patient has been out of the workforce for 2 years or more, please list any additional medical conditions that prevents them from regularly working at any job. Attach available supporting documentation. So this is code for late applicants. So this is the individual that has run out of earnings and contributions. So their contributory period is in the past. And basically what it means is that in spite of being terminal, we may have to look historically at any other medical conditions that they had in the past to qualify them. So I'll just give you an example of where this occurs. So hypothetical example, 2010, the client is laid off from their job. Maybe the plant closes and they send their jobs off to Mexico. So they've been laid off from their job. And at the time of being laid off, the applicant has a number of medical conditions. Maybe they've got a heart condition and a degenerative disc disease and maybe some depression. They've got a sort of a cluster of medical conditions, but they're still lumbering along and working. But now they've been laid off. Because they're not feeling well, they don't seek out additional work. So after 2 years, their contributory window ends. 3 years later, they find out they've got terminal cancer. Because the cancer came after their contributory period ended, we can't grant them on the basis of that cancer. We will have to go back in time to when they last met the contributory window and look at the cluster of medical conditions that they had at that time. And perhaps by combining those together, there might be enough medical evidence to grant them at that earlier date. All right, so for those of you who are listening to the recorded version of this webinar, you probably will not have received the forms through the email. So if you need to go and download the forms, the next 2 slides describe where you would find the forms. So the first page is for the regular application kit, and then the second one is for the terminal illness application.
Thank you, Jane. Now we're going to answer a few questions that we have received throughout the presentation. Jane, there was a question around the ICD-9 toolkit. Is it available online while they're filling in or downloading the application?
Okay, so that's a good question. So at the present time, the forms are fillable PDFs. Okay, so we don't have like an ICD drop-down menu, if that's what you're asking for.
Yes.
But eventually, in the near term, we are moving to make these forms truly electronic, where you would actually fill them out online. And it's my understanding that they will embed an ICD-9 drop-down in the electronic versions of the forms, but currently it's not available.
Okay, thank you, Jane. That's great. There was a participant who was not able to download one of the PDF.
Okay.
So is it potentially because of her computer or technology? Have you heard any issues?
I haven't heard any issues. We can deal with that. We can try and resend it to her. Maybe the file got corrupted when it was sent by email, or I don't know if they downloaded it from the internet or if they took it off of the email.
Took it off of the email.
Okay, the file may have just been corrupted in transit. We can resend it.
So we will resend it. And there was another question around section 4.
Is that the regular kit or the terminal?
The terminal.
Okay.
If the patient does not meet the terminal or grave definition provided, how would a progressive metastatic cancer fit in this section, or would they
Right. So, sorry, I'm just opening up the forms here so that we're looking at the same thing. Okay. So in section 4, you've got 2 options. You've got terminal and you've got grave. If you take a look at the list of grave conditions in Annex A, you'll see that 80% of the conditions in that list are actually metastatic cancers in most cases. So if the individual is not, if the prognosis is such that you don't anticipate death within 6 months, the grave listing may still be relevant.
Okay, that's useful.
Yeah, so if you look here, I'm just looking at the Annex A. So if you just glance your eye down the list of 32 cases, 70 to 80% of the conditions in Annex A are cancers. So that person may not die for another 2 or 3 years, but their condition is still very, very severe, and the treatments themselves may be debilitating. So we would want to put those people in the fast queue, but not the fastest queue.
Not the fastest, but the second.
Yeah.
The second group, the grave, under the grave definition.
Right.
There is another question, Jane, about why is there no federal provincial tax taking off when the lump sum retro payment is awarded? Do you know why?
I'm not an expert in non-medical issues, but it's my understanding that it's at the discretion of the applicant to have the tax withheld. There's a form, I believe, that the client has to fill out, and I can't speak to it specifically. I should look into that further. I'll see if I can find an answer to that question for you. But I believe it's at the applicant's discretion of whether that tax is withheld at source or not. I'll have to look into that further.
That's good, Jane. There's another question about perhaps other metastatic cancers that are not on the list and would fit the criteria. So could it be up to the clinician to put the patient in that category, or is this?
Okay, I don't know if you're referring to breast cancer. That's one of the cancers that's actually not on the grave list. And the reason is that one of the criteria for putting a condition on the grave list is that the grant rate has to be around 80% or higher. And with all of the advances in the treatment of breast cancer now, we're finding that many of those individuals are able to work for some time before they actually have to come on the benefit.
Actually, the example provided, Jane, is head and neck cancer. Are they on the list?
I think that's on the list, actually. I haven't looked at the list in a while now, but I'm pretty sure it is.
So we're looking back at the list, and Jane thinks those are on the list. I think I saw the neck cancer.
Let's see here. Brain cancer is there. Number 7 is brain cancer.
So brain is there.
Thymus cancer 31.
So we're just looking at the list right now.
I have Dr. Pierre Barassa sitting beside me, and he's looking as well. Thymus cancer is number 31.
So there are 2 examples of where the patients would qualify in that category.
Esophageal cancer, number 11.
That's what I thought.
Yeah.
So there are a few examples in the list.
One thing that I should also mention is that when these applications are received in the mailroom, they're shipped over to the processing area, and we have the equivalent of sort of a triage nurse that looks at these applications as they're coming in. So there is kind of a manual review, and so if for whatever reason, you feel very, very strongly that this person needs to be advanced in the queue, you can indicate that on the form and somebody will look at it. So there is somebody with a medical background it's not just going to a non-medical person, it's being looked at medically first before it goes to have the earnings and contributions calculated.
Thank you, Jane. One last question is about how long does it take Service Canada to render a decision for initial application?
So for a regular application, it's on average about 120 days or 4 months. So this is why the expedited processing for terminal and grave is so important, because we can condense that 4-month period into either 5 days for terminal or 30 days for grave. But again, as with everything in life, if everything is urgent, then nothing is important, if you know what I mean. So we have to have some means of triaging. So that's why we're applying these sort of definitions to put people into the appropriate processing queue.
Thank you, Jane. Another question about recourse of the applicant if their application is denied. Is there any
so if the application is denied, the client is offered an opportunity to present their case again at the reconsideration stage, and reconsideration happens within the department, but it's done by a different nurse. So these are all nurses that are assessing these applications. So it's a different set of eyes, essentially. And at the reconsideration stage, the applicant is invited to submit any new information, and the same thing with the healthcare provider, if there's any additional information. Maybe there's been, further investigations or further consultations that can now be used to embellish the file. You can send those in at the same time. At initial, the client will receive a denial letter explaining why they were denied. So ideally, both the client and the healthcare provider will want to address what those gaps in information were when they're requesting the reconsideration. One thing with the reconsideration too is that they have a 90-day period to request that reconsideration. So even if, let's say, they're waiting for another specialist appointment or another, an MRI, let's say it's scheduled 6 months in the future, they should still file their reconsideration immediately and identify that they're waiting on more test results.
Jane, are the ICD-9 codes a new requirement in the forms? Because someone said that they were not using them in the past.
Correct. So the reason that we're asking for the codes is that we're starting to do some predictive analytics, meaning we're trying to identify trends within our caseload so that we can more appropriately respond to the needs of our clients. It is new. Again, we're having some growing pains. So, if you put the wrong code, don't panic. Like, it'll get corrected, but to the extent that you can put the correct code, it will help us speed up the processing.
One last question that I see is if the previous forms will get accepted, or are they?
That's a really good question. Yes, absolutely. There is going to be a grandfather period. We recognize that healthcare providers often download these forms and make photocopies. So you may have, a stash, 6 months worth of the old forms. And if you're still using the old forms, we're not going to turn anybody away. We'll continue processing using the old forms. But it's to the client's advantage for you to use the new forms because of the stronger focus on function. It's not the diagnosis alone that's going to get that client granted. It's understanding the impact of that diagnosis on their function, their ability to undertake tasks and activities in daily life as they apply to work. That's really what we're looking for. It's primarily a test of employability. You can have 2 people applying with fibromyalgia or chronic pain. One is granted, one isn't. They both have the same diagnosis, maybe the same treatment plan, but one of those individuals is responding better to the treatment plan than the other, and that's what makes the difference in terms of whether they're granted or not.
Jane, are you seeing autism as a common diagnosis with the applications?
It is not a super common diagnosis, no, because our program only caters to people between the ages of 18 to 65. So if the autism was so severe from childhood, they likely never would have acquired a sufficient work history to qualify for the benefit. We have seen a few cases where individuals were working perhaps in a benevolent or a sheltered work environment, maybe a family member or their local minister or priest, for example, hired them kind of in a sheltered environment, and they were able to acquire sufficient contributions, and then for whatever reason, the employment terminated, and so now they're applying with that diagnosis. We do see it, but it's not common. And those, again, we look at those cases on a case-by-case specific basis.
Thank you, Jane. That's the end of the question and answer period. I really wish to thank you on behalf of CNA and on behalf of the nurses and nurse practitioners who are completing these forms. And we will have a few questions for the participants just to see how you found the information today, useful or not. And then we'll have more information about Jane, how you can reach her.
Thank you, Josette.
So this is Jane Graham's email address if you're interested in having a bit more information about the changes. And we will also have the webinar recordings available on the YouTube channel. And wishing you a great day and encouraging you to attend our next webinar in October on cannabis.